to do an ECG for this patient, and the ECG, I wanted to show the picture before, but I think I just summarized it. Shows sinus tachycardia with some pathological Q waves. The Q waves were in the leads 2, 3, AVF, leads 1 and V6. We also went ahead to do the troponin for this patient, and the troponin was through the roof. I mean, it was above the upper limit of detection of the qualitative stuff that we use. It ranges. It can range between 550. Normal should be less than 50 to 2,000. For this patient, it was greater than 2,000, which was extremely high. Also, the D-dimer was elevated. I don't know what you think about that. On the full blood count, we could see a mild leukocytosis and neutrophilia, and the malaria test was also positive. H. pylori was positive, and of course, the cholesterol parameters were deranged. Okay. What do you think about that?
Before I make a comment, I can see that some of our people are saying they've not been able to hear us. Okay, I think we are on here. Maybe we will quickly do a quick recap of that case. It's like when we started the case, most people couldn't hear what we were saying.
Okay, so I think I'll just summarize the case again now. So the case we're discussing now is that of a 48-year-old man who presented with chest pain, acute chest pain actually, starting 24 hours before presentation. And he described the pain as being a heaviness in his chest, said to be very severe with a score of 10/10. He did have some dyspnea, which was worsened by exertion and relieved by rest, and also relieved by antacid. Sorry, the chest pain is relieved by antacid. He had nausea and vomiting, but no cough, no diaphoresis, and all these other symptoms that were listed. And on examination, the key thing on the initial examination was that he was in painful distress. And he had not really tachycardia, but the pulse was 92 per minute, and then he had this ectopics, and he had bibasal reels on auscultation of the lungs. And I was describing that the ECG did show some sinus tachycardia with Q waves in the inferior leads and also in 1 and V6. Okay. So yes, I was asking you what you talked about that. So in addition to the laboratory
you can now see now that the first examination, the pulse was normal, but by the time the patient had the ECG, the patient already had tachycardia and with pathologic Q wave in the inferior leads.
Yeah.
That is in the area of distribution of the right coronary artery, and some also in the lateral leads in lead 1 and V6. And now looking at the cardiac markers, we can see that the troponin was severely elevated because the cutoff for our troponin here, I think, is around 50. So for someone to go from 50 to 2,000 showed the degree of myocardial injury the person sustained. And we can see some of the blood picture there, which is common in patients with heart attack. They have this neutral, this leukocytosis that look like an infection-like picture, which is common from them. There may be associated infection, but you could also find that in patients with heart attack without an infection, and you can see how deranged the cholesterol is. So we can quickly see some of the risk factors right from just doing the laboratory check.
Now, looking at this malaria parasite that is positive and the H. pylori that is positive, do you think that has an inkling with it?
It could be a coexisting morbidity. Like we said when we started, the fact that the patient responded to antacid does not mean that the patient had PUD. And the fact that someone had an heart attack does not mean that the person could not also have a peptic ulcer disease at the same time.
And my problem with this many times is that it will serve as a distractor. So some people will just see the malaria somewhere peripheral, and then just focus on that, no, it's malaria. We did the test and it's positive, and you're treating someone with heart attack for malaria. The echocardiography was also interesting, which showed actually that even though there were no features of hypertension on the ECG per se, the LV size and thickness were fine, but the ejection fraction was already getting reduced as well. So, I mean, I think this is an interesting case, and I think as we delve into this case, we'll show more light on it. So, Dr. Olalekan, I want you to start by what's myocardial infarction, first of all, and then how is it different from how is myocardial infarction different from what we call acute coronary syndrome?
Okay, thank you very much. Myocardial infarction,
yes,
is under the spectrum of what we call it's under the spectrum of the umbrella of acute coronary syndrome. And by extension, acute coronary syndrome is also under the broad family of ischemic disease.
Okay.
Ischemic disease, generally, we can say stable angina, or stable angina and acute coronary syndrome. And acute coronary syndrome is a clinical syndrome that is made up of unstable angina, non-ST segment elevated myocardial infarction, and ST segment elevated myocardial infarction. And what differentiates this is, one, the presence of cardiac enzyme, as in evidence of myocardial injury.
Biochemical evidence.
Biochemical, which is the presence of positive cardiac enzyme in the blood, and the way they presented with the pain. In somebody with stable angina, which is under ischemic disease, what you have is a fixed defect or fixed obstruction in the blood vessel. So the person presented with pain that's predictable, lasting short time, within 5 minutes, relieved by rest. But by the time you get to the acute coronary syndrome, what you have is, in unstable angina and non-ST segment elevated myocardial infarction, what you have is like a partial obstruction of the blood vessel. So the patient now presents with severe type of pain. The patient can have pain at rest. The pain is of longer duration, worse in severity, and now the pain gets longer, about 20 minutes, 30 minutes, and with the patients not sometimes responding to nitroglycerin, rest will not help. So by then the patient has moved from the area of stable angina to acute coronary syndrome. And by the time you now go ahead and check for the presence of cardiac enzyme, once you are able to identify cardiac enzyme in the blood, then the patient now has moved from unstable angina to myocardial infarction. And that is why where your ECG now comes in. You do your ECG and you find elevation of the ST segment on ECG. Then you can now say whether this patient now has a non-ST segment elevated myocardial infarction or ST segment elevated myocardial infarction.
Okay, so that's quite an handful. I'm sure by the time we're talking of the evaluation and the management, hopefully we'll delve a bit more into this. So how does the coronary arteries get blocked? I believe that it was patent before and then again. So how does that process happen that someone's coronaries just decide to get blocked?
Coronary artery can get blocked in numbers of ways, but the most common and the type 1 under the classification is due to atherosclerosis. So at the base or at the foundation of obstruction of the coronary artery is presence of atherosclerosis with formation of the lipid core. So what can happen is with time, the cap of that atherosclerotic area can get eroded or broken. And once that happens, what you now have is you now have the presence of platelets, inflammatory products now aggregating in that area. So you have platelet aggregation now forming, and with blood cell, red blood cell, fibrin forming mesh, and gradually the caliber of the coronary artery gets reduced gradually. And like I said, once you have a partial obstruction, then patients start having pain, even at rest, longer duration, worse severity. So the patient now has entered the unstable, and the unstable is between unstable and the non-ST segments elevation MI. When the atherosclerotic lesion is fixed, that's stable. But once you have increased platelet aggregation, thrombus formation, then you now move on to get to a point where you have a total obstruction of the coronary vessel. Then that is the extreme. That's the ST. By then, the ST segment is elevated on ECG, and patient now has ST elevated myocardial infarction.
Okay, so that's quite interesting. So basically, what you're saying is that the plaque events, as the plaque is evolving, the patient can evolve. Sorry, the patient can evolve from having a stable angina to an unstable angina to what we call an ST segment myocardial infarction. Basically, that's what you're saying, right?
Yes.
Okay. So, what's the epidemiology of coronary artery disease? How common is coronary artery disease globally and then in Nigeria as well?
In the past, we used to say ischemic heart disease, myocardial infarction is not common in Nigeria, but
Okay.
the trend is changing seriously. In 2016, the WHO actually estimated that about 18 million people died from cardiovascular diseases. And out of this number, 85% of them are due to heart attack and stroke. The number one being the heart attack, which is the myocardial infarction that we're talking about.
Yeah.
And in black,
Yeah.
though we don't have a lot of data in Nigeria, coronary artery disease is still responsible for a quite number of deaths in Nigeria. About 2.8% of deaths was due to coronary artery disease, and due to increase in the prevalence of risk factors, the hypertension, hyperlipidemia, diabetes, obesity. These risk factors are increasing, and so we're getting to see more people presenting with this condition. And it will be alarming if I tell people that here in Cardiocare, maybe because of the high-end procedure and intervention we do, that every day we get to see patients with heart attack. It is that, don't let me say use the word it is that bad, but it is that common that virtually every day we see patients with heart attack. So though the data is still very few and scanty here and there, institutional based data, but this is a trend that is on the rise.
And I know that diabetes and hypertension, which are the major risk factors for coronary artery disease, are actually rapidly on the rise in this part of the world, particularly sub-Saharan Africa. So it's actually totally expected that the increments in risk of coronary artery disease will follow it. It's actually quite interesting to me that, I mean, the way we see stroke here is almost the way they see myocardial infarction abroad, even though they see more. But of course, we're having more and more MIs now, and I think we're starting to recognize it more and more. In terms of comparing us to the Western world, what would you say is the difference in prevalence is like, and any other key things about the prevalence of the coronary artery disease?
Comparing us to the whites, due to increase in awareness in their area, good health system, good emergency services, the trend in the developed country is actually coming down because of quick response. Emergency service within 30 minutes, 90 minutes, you can actually get to identify patients and give appropriate treatment. The trend both in mortality and even in the prevalence is reducing. But when you now come to our side in Nigeria and the black area generally, one, due to the increase in the prevalence of the risk factor, like I mentioned about, poor awareness, number two, poor health seeking habit, number three, and non-availability of diagnostic diagnostic services, we can see that we are actually on the rise. And coupled with the infectious disease body that we already have, that's just a double blow on an already weakened system.
I've mentioned some of the risk factors of coronary artery disease. I did mention hypertension and diabetes. You mentioned it's a bit commoner in the Western world. You mentioned why it's actually, even though at least in US, you said that it's actually more common among blacks, perhaps. So what would you say is the risk factor for coronary artery disease, generally speaking?
Risk factors for coronary artery disease is similar to risk factor for cardiovascular disease.
Absolutely.
Generally. So, and like we used to divide it right from medical school to the ones that we can do something about and to the one we don't have any power about. The non-modifiable, there's nothing we can do about our risk. Sorry for the for the mix-up on the slide.
Okay.
The non-modifiable, you can't do anything about your race, about your gender. Gender, like we talked about, both stroke and heart attack is commoner in male compared to female. But after menopause, the ratio is almost the same. Like we said, it's commoner in black. Even in the developed country, it's commoner among the black American compared to the white. Family history of cardiovascular disease, family history of ischemic heart disease,
especially if it's premature, happening before the age of 50 or 60.
So it makes one more predisposed to development, to having heart attack.
Okay. What of the modifiable? Let's focus on
modifiable. This is what we can do things about, and that's one of the reasons why hypertension, diabetes, like we mentioned, very, very key. Smoking is another key modifiable risk factors that we need to watch out for.
And I think people are tending to smoke a bit more in Nigeria now than before.
Because we're changing, the lifestyle is changing. Both male and female were smoking, but both is it first direct smoking and indirect smoking. Problem with lipids, sedentary lifestyle, obesity, psychosocial stress. But like I said, the major ones are smoking, hypertension, diabetes, problem with lipid, and family history of premature coronary artery disease.
Okay, thank you very much for answering that part. Of course, I know that there are some things that we call novel risk factors. Well, I think some of them are actually a bit high-falutin stuff, and it's important to make sure that we address the traditional risk factors before we start exploring for some more. But which of the novel risk factors would you feel is notable of being mentioned?
I want to mention one, HIV, AIDS. Because with improvements in treatment, with arts, quick recognition, management of opportunistic disease, people with HIV AIDS now, the mortality is reduced, they live longer, so they can have vasculitis in both. As part of the vasculitis, the coronary artery can also be affected. And some of the medications too also alter cholesterol,
the protease inhibitor.
So all this coming together, so makes them more. So this is one of the novel risk factors that we have to pay close attention to, and also presence of end organ damage, like especially patients with end-stage renal disease.
Absolutely. So how do we classify myocardial infarction? How will we classify it? We've talked a bit about stable angina, acute coronary syndrome spectrum, but the MI itself, how do you classify it?
Myocardial infarction is classified based on the underlying pathogenesis into 5. So I'll just mention it quickly to make. The first one is the most common one, the one that we discussed, that is due to atherosclerosis. That's the first one. The second one is due to imbalance between the oxygen demand of the heart muscle and the oxygen supply. And this range from something as simple as what we call Prince metal angina, which is just due to vasospasm. That is constriction of the blood vessel, of the coronary vessel. There is no atherosclerosis, the vessel is clean. Then something like anemia. Anything that will increase the oxygen demand of the heart, tachycardia, infection, fever, hypotension from any cause. That's type 2. Then type 3, we talked about if someone you suspected had MI, but before you are able to check the cardiac enzyme, you lost the person. So you are not sure. So that is type 3. Then why type 4 and type 5 are related to procedure. So myocardial infarction following percutaneous coronary intervention is in type 4, and in type 5, I think those are the one following coronary artery bypass grafts. So those are the 5 looking at the underlying pathophysiology. Then based on the ST segment changes, like we said, when you do your ECG, if there is no evidence of ST segment elevation, so the patient has a non-ST elevated MI, no change in the ST segments on the ECG, and there is presence of myocardial injury, that is, you are able to identify cardiac enzyme in the blood. The patient has a non-ST segment elevated myocardial infarction. And once you have abnormality in the ST segments, then you have end-stage.
Okay, I think before we go further, I think we should take the first poll. Let's launch the first poll, and I will encourage all our audience to participate in the poll. That's one. And then secondly, let's drop our questions in the Q&A box as much as possible so that we address them close to the end of the presentation. So here is a poll, and we have the questions here. The question says that which of the following is a recognized cause of myocardial infarction? Option A, atherosclerosis. Option B, systemic vasculitis. I think this one is a multiple choice, so you can choose more than one. Option C, massive upper GI bleeding. Option D, GERD, and the last option says pregnancy, which is a recognized cause of MI. You can choose more than one option, actually. Let's see how the people will choose. Okay, at just 1 minute, 10 seconds, we can stop the poll.
Okay, I think we can stop the poll.
Okay, I think we can stop there. Okay, so most people, I will leave you to comment on it, please.
So most people went for atherosclerosis, like we said, that's the commonest cause, underlying cause in heart attack or myocardial infarction is due to atherosclerosis. But like we said, vasculitis, systemic vasculitis, right from HIV, systemic lupus erythematosus, or anything, any systemic illness that can give vasculitis can also affect the coronary vessel. So,
one of the massive property I saw a guy once, the Caucasian, and he had a myocardial infarction during a massive operative bleeding. I think he went through that anemia pathway.
Yes, so it will go under the type 2 of MI.
Absolutely. That we talked about. And his coronaries were actually clean. Okay, but he had the MI, and so that's part of it. But GERD and pregnancy are not really recognized.
Directly related.
Okay, thank you for participating in that poll. Also, we move on now, and I'll ask you again on the. So you talk about the risk factors, but what are the etiologies? I think it's probably related to the classification of coronary artery disease. What's the etiology?
The etiology is just restating the classification we talked about. Number one, mainly atherosclerosis.
Okay.
Then other non-atherosclerosis, atherosclerotic condition include the metal angina that we talked about, vasospasm, patients with vasculitis, arteritis. Drugs can actually cause constriction of the coronary vessel. Drugs like cocaine,
and we've
seen people like that, young people, after taking drugs, coming down with severe chest pain
and infarction.
They have to go in through the Cathlab, the blood vessel very clean, but from history, we're able to pick that. So, and also, we should not forget that as part of embolic events, the same way someone can have stroke, someone can also add embolus
into the coronary
artery. So, those are other non-coronary artery. Then you can have arteriovenous malformation, aneurysm, and other conditions that increase oxygen demand of the myocardium, exercise, fever, systemic illness, and all that. But overall, over 90% is due to atherosclerosis.
Okay, so how do we determine whether a chest pain is angina or not, and whether a chest pain is perhaps from the heart or not? How do you make that determination?
Thank you. I first of all want to say, what is the characteristic of an angina, a pain from the heart? What is the characteristic? And the American Heart Association put 3 typical presentations. Number one is where is the location of this pain or discomfort? It is located retrosternal or substernal. That's one.
Absolutely.
Number two is what is the aggravating factor?
Oh, yeah.
So an angina is precipitated by exertion or any form of stress, either physical or emotional stress, and it's relieved. That's number 3, by rest or use of nitroglycerin. Those are the 3 typical things that qualify angina. When you have all these 3, that's typical angina. If you have 2 atypical, 2 or 1 atypical, but if you have none of these or 1, then it is not an angina. But now describing pain that is due to myocardial infarction itself. It is a bit different from this angina. This typical angina description is what you find in patients with stable angina. But by the time the patient now moves into acute coronary syndrome that we talked about, that include unstable angina, end-STEMI, and STEMI.
Okay.
The patient now has 1, pain at rest. I talked about typical angina that is provoked by stress.
Okay.
But in someone with myocardial infarction, the pain could start from rest. The pain could start after a meal. The pain could start just after shouting, some just little emotional disturbance. The patient can have pain. 2, the pain now is longer. The pain lasts about 20 to 30 minutes. The pain has what we call a crescendo pattern. Is getting better. This one is worse than the last one, longer than the last one, precipitated by less stress or even at rest.
Okay.
Then the patient may not even respond to nitroglycerin or rest. So that now brings the patient now to the level of unstable angina or STEMI, as the case may be, once you are able to identify presence of cardiac enzyme.
I will ask that out of all these features that suggest that a patient may be having an MI, which one would you consider to be the most, perhaps the most discerning or the most suggestive? Is there any such?
The most suggestive would still be the pain. But we should not forget that someone can have myocardial infarction without pain. That's one of the things we want to note. And this is usually found in elderly patients, patients with diabetes due to the neuropathy they have, women, and patients with heart transplants. These people can actually present without pain. Pain is the most discerning, but it may not be present in patients with cardiac infarction.
Okay, thank you very much. So apart from the pain, which you have mentioned, in the case scenario we described earlier, the patient also did have some shortness of breath.
Yes.
Patient also did have some nausea and vomiting. Which other symptoms or clinical features, let's start with the symptoms, obviously, is suggestive of myocardial infarction?
So apart from pain, other associated symptoms the patient could present with include dyspnea.
Yeah.
The patient can present with extreme fatigue, extreme weakness.
Yes.
Some patient can actually come with syncopal attack.
Next.
Syncopal attack from arrhythmia, because like we said, they are prone to development of a lot of arrhythmia. And some of them might actually come with a condition we call angina equivalent. The patient has no chest pain, but you just find someone vomiting, someone just acutely confused, someone just feeling extreme tired, extreme fatigue, no pain, nothing, and I'm not just feeling fine. So we should watch out for something like that.
Okay.
In the class of patients I talked about, elderly patients with diabetes, so they just present with things that are atypical, things that are not specific. So you need to have a high index of suspicion to be able to say, could this be due to an acute coronary syndrome, and not just say the patient is malingering, so let him go and come back.
And I've seen such mistakes more than a few times. So what are the common mistakes that we make when seeing a patient with coronary arteries? I know you mentioned earlier that saying that because the patient responded to nitrates or the patient responded to antacids, the patient did ask this or ask that. What are the common mistakes that we often make?
Okay, thank you very much, sir. Some of the mistakes that we want us to avoid is one, we talked about pain, and we said someone can have atypical presentation with this pain, and
Okay.
there may not be pain at all. That's number
Okay.
one.
Okay.
Number two, the fact that the pain gets better with antacid does not rule out an acute coronary syndrome. Number three, the fact that someone also gets better after you use nitrate does not 100% qualifies for an acute coronary syndrome. You still have to look for other things.
I actually had a patient once that it wasn't outside the country. I think it was in London actually, and he said that when he went to the doctor, they were not quite sure what he had. So they told him that pain that he used to have, he should run up the stairs. If he has a pain, he should use the GTN spray. And if he did use the GTN spray, the pain went down, that is definitely, and then that's when he should do it. What do you think about that kind of a practice?
I think it's not a very, very good practice, because like I said,
not the evidence-based practice at least.
A patient with esophageal spasm will also get better
with that,
with nitrates.
And then there's this placebo effect that we know happens with many conditions. So that it doesn't hold water that much at all. Okay. So going further, if we see a patient with acute myocardial infarction, or a patient with chest pain that we suspect can be acute myocardial infarction, when we're examining such patients, what are the things that we should look out for on examination?
Okay. I quickly want to point out that, as we know, this is an emergency.
Absolutely.
And so this is not a situation where you want to go to town, be looking for every sign,
be checking for the patellar reflex.
But there are some things we can quickly check to aid our diagnosis, right from just looking at the patient. Like we said, these patients are not comfortable. So you walk into your emergency room and you find a patient that is restless, that is just finding the person is just looking for the most comfortable position, but is not able to find. Then you walk into the emergency, you see your patient with his fist on the chest, what we call a Levin sign. The patient is just trying to get better, just trying to point, I'm not just feeling comfortable here. So right from looking at the patient, you know there's something wrong. You quickly want to assess the oxygen saturation of the patient. Just put your pulse oximeter and your SpO2 is giving you 89, 88, you know something is going wrong. And due to vasoconstriction of the skin looks clammy, the skin looks pale, the patient is sweating, you know, yes, something is off here. And when you have time to go on to do a laboratory thing, you cannot start checking for pulse, you can have tachycardia, you can have bradycardia, there could be hypotension, depending on the artery that is affected. So you can have different type of presentation in the pulse. Then the axon, if there is associated heart failure, you pick a third axon. If there are other diastolic dysfunction, patient could have a fourth axon due to branch lock or delayed contraction. You can have splitting of the second axon. So a lot of things you can find. But like I said, this is not the time to be doing a very comprehensive, because time is of essence here. The more time you waste, it's like the brain. The more time you waste,
the worse the
outcome, because you lose more myocardial tissue. So you want to be fast as much as possible.
Okay. Thank you very much for highlighting that. I think before we go further, we'll take the second poll. Let's take another poll. Please, let's all try to participate in this. I will appreciate it. Okay, so we have this question. A 49-year-old bank executive presented with a 2-hour history of heaviness in his chest, weakness, and diaphoresis. He's not a non-hypertensive or diabetic, though diagnosed with hyperlipidemia. Which of the following investigations is the least urgent? Least urgent. Not most urgent, but least urgent. Which is the least urgent? Least urgent. So perhaps all the investigations are relevant, but which one is the least urgent? think you can stop at a point of a minute. What do you think?
Okay, thank you for participating, and I'm happy that people chose chest X-ray.
Many people chose, not everybody.
All,
61%.
all the investigations are relevant, but the question is, which one is the least urgent? Chest X-ray seems to be the least urgent here because things that you want to do as fast as possible
Absolutely.
are ECG and
Troponin.
your troponin.
And of course, the glucose too.
So the glucose too is something that you can quickly do along the line. But we have to go to the radiology, check the chest X-ray. It is good for us to identify some other differential diagnosis.
Absolutely.
Because it is not only myocardial infarction or heart attack that causes chest pain, but on the order of priority is the least in this poll.
Okay, so thank you for participating in the poll. So now we've discussed this, we've mentioned this case that we talked about. So how do we establish a diagnosis of myocardial infarction? Person has a chest pain, maybe you thought it's typical, maybe we're not even sure, maybe it was atypical, but we were trying to evaluate the patient. At what point can we say that this is an acute myocardial infarction?
Okay, thank you, sir. Once you see your patient, we want to make it as practical as possible.
Absolutely.
You see a patient presenting with either the typical chest pain,
okay, or
what you suspect to be an atypical chest pain.
Okay.
The first thing you want to do is that initial resuscitation measure I talked about.
Okay.
You want to assess, is the airway opening, is the oxygen saturation fine?
Okay.
And as you are doing that, you are quickly getting those important investigations we talked about. Quickly ask for the ECG.
Okay.
Take your blood sample, send for troponin. You can check for your blood sugar, put in a line, and quickly ask your question. Your ECG, as you're doing your ECG, you're getting your ECG is something you see almost immediately, and you can see clues on the ECG that will help you to nail your diagnosis.
Before we go deep into the ECG, can you go back to the slide and stay where we have, please? Okay, good there. Mm-hmm. Okay, so before we go deep, so the key things that you mentioned is that when we see a patient that's presenting with an acute chest pain, number one, we need to be fast.
Yes.
And the ECG is one of the first things we should get.
Yes.
It's impossible to actually really evaluate someone presenting with an acute chest pain without doing an ECG. Okay, so that's critical. So that's one. Which other investigations you mentioned that should be done urgently?
Troponin.
Okay, so we should get the troponin.
Where you have the facility, get the troponin.
Okay.
Number three, like I said, assess the oxygen saturation of the patient. And if the oxygen saturation is below 90%, place the patient on intranasal oxygen. Then you can now, after that, start your general measures while you are waiting to evaluate your ECG and evaluate your troponin.
Of course, it's also a good idea. By the time the blood is drawn for the troponin test, the other basic cardiovascular tests can also be run from the same sample: the EUCR, full blood count, lipids, A1C, and the random blood sugar can be done at that time. I know that a lot of people that don't do ECG that fast for this kind of patients. Of course, some don't have ECG immediately available. I believe that most hospitals have that. So that's for some people, because they cannot read the ECG themselves. And maybe it's 2 a.m. They feel like, okay, if I do the ECG anyway, who is going to read it? So I hope that you're going to just highlight some things that people should look out for on ECG or someone with chest pain that can suggest that this is. So what are the key things you should look out for on such ECGs?
The key things we want to look out for on ECG, we'll still draw more on this by the time we talk about ECG tomorrow, is one.
Yeah.
We want to see whether there is ST wave changes on the ECG. Because depending on the time that you're seeing the patient, the change in the ST and T wave area is a continuous and a dynamic thing. So if you get the patient early, what may be there may just be a tall T wave, what we call an hyperacute T wave. And later, patient now start having ST segment elevation, T wave inversion, and Q wave. So you are trying to look out for this ECG. And like we said, we must get this ECG as fast as possible within the first 10 minutes if it is possible. And we might need to do more than one ECG. What is actually recommended is a continuous ECG monitoring, because like I said, this is a dynamic thing. So the fact that the patient came into the emergency, you check the ECG, you did the ECG, and the picture looks normal, does not rule out an ACS. So do within the first 10 minutes. If there's nothing, repeat within the next 15 to 30 minutes, then 3 hours, 6 hours, then you can start checking 12 hours. But if you have the opportunity of a continuous cardiac monitor, you can actually place the patient on a continuous ECG monitoring, and you can do a continuous, see the waves. So that is important. You want to look at that on the ECG. Then some people might have just a left bundle branch block pattern. All this we'll talk about in details later. So presence of a left bundle branch pattern, especially in a patient that you've seen before, you have the opportunity of having the old ECG. So the patient comes in with a chest pain, or you are suspecting myocardial infarction, you did the ECG and you have a left bundle branch block pattern. That is a marker that was not there before. That's a marker for
I think you have a slide on ST segment elevation. So let's see the slide.
And we'll go to that slide. Okay. So on this ECG, the pointer 2 is the J point. That is where the S wave ends and the T waves on the ECG starts. So you are looking at that point, and what you are looking for is you are looking at the elevation of that segment away from the baseline.
Okay.
And you want to call,
where's the baseline?
The baseline, that is the, oh sorry, I don't have the cursor. That is the line that's from the point 1. If you draw a line along that point, that is what the isoelectric line is. That's the baseline. So from that, you can now calculate how far the distance of your ST segment from that line.
Absolutely.
And the WHO classification, European Society of Cardiology classification, says that from that J point, the ST segment, once your ST segment is greater than 1 millimeter from that J point, using that baseline, the patient has an ST segment.
So just
elevation.
one small square.
One small square from that baseline.
I see.
And in lead V2 or V2, V3, once it is more than 2 millimeter, 2 small square in men and more than 1.5 small square in female, the patient has ST segments elevation.
Okay, so a lot of people don't know what a Q wave looks like. Can you show? I think there's a slide on the Q wave. Just go to slides forward. Okay, so here we go. Back, So
okay, the Q wave is the first negative deflection in the QRS complex. The first thing that comes down from that baseline, that's our Q wave. And so for a Q wave to be pathological, because in some leads on ECG, you can actually see the Q wave and they are normal. But once your Q wave, once the depth is more than 1 small square, and the width too is also larger than 1 small square, that Q wave excuse me, that Q wave is pathologic. So you are looking at both the depth and you are looking at both the width of the Q wave. So once that is more than 1 small square, then you can say that the patient has a pathologic Q wave. And
the next 2 slides,
and is an indicator of an extensive myocardial infarction.
Will this pass for Q waves?
If we look at V2 and V3 on this ECG, we can see how deep that first negative deflection is. I don't know if you can put your cursor on the Q wave in lead V2, just trace it out for people to see, and V3.
I wish you could actually zoom it.
So you can see that thing going down. It's obvious it is more than one small square. Yes. And if you look at the width too, it's also a bit wider than, okay, thank you very much, than the one small square. And if you now look at the ST segment, if you can raise your cursor up a bit, yes,
that's it.
Exactly. That place, the J point, you can see. Look at the baseline from where V3 is written. It's almost five small square there. So it's obvious that this patient has an ST segment elevation in V2, V3, up to V6. So this patient has an extensive infarction.
And the difficulty that people have sometimes is in teasing out that Q wave. The only thing you need to look for there is that there is no first positive deflection.
Yes.
If there was a first positive deflection, that would have made it a S wave. But here is just a Q wave, or you can call it QS wave.
And before we leave this slide, another thing that we also see on ECG is the lead opposite where you have the infarction. We have what we call reciprocal changes.
Absolutely.
So here from V2 to V6, you can see that the S segment is up. So those are the area that's affected, the anterolateral area. But when we now look at the inferior leads, the lead 2, 3 AVF, but more pronounced in lead 3 and AVF here, we can see that the ST segment is going down and the T wave is inverted.
Absolutely.
So that is what we call a reciprocal
change
in the opposite. It's like the man in front of your house is dying and you are crying, you are wailing, so that is what we see in the lead facing that area. So that is what we call it.
So what are the sequential changes that we have in the ECG? Next.
So the sequential changes, like I talked about, from normal, the first thing you see is acute elevation of the T wave. You have what we call an hyperacute T wave. It's not actually shown on that slide.
Okay.
Then few hours after that,
actually, most times you don't catch that.
Yes, because the patient would have gone, especially in this area where we have late presentation. So the next thing, hours, now the ST segment is elevated while the T wave is still upright.
Okay.
Then days, what you have is inversion of the T wave. The ST segment is still elevated. Let's go back to that slide. The ST segment is still elevated, then your Q wave starts appearing. And as your ST segment is coming back to the baseline, the Q wave starts increasing, then your Q wave will actually be there permanently. Absolutely. And the ST and T wave comes back to normal. So when you have presence of Q wave, pathologist Q wave, it can be an indication of an old coronary event in the patient.
Absolutely. So now we've been talking about lateral lead, inferior leads, and those kind of groupings. Can you just explain to the people so that we know how we group the leads and what leads we should look at and interpret together?
Okay, thank you very much, sir. This will still be talked about elaborately tomorrow during the ECG presentation.
Sure.
We group the leads into leads looking at the inferior part of the heart, those looking at the lateral part of the heart, and those looking at the anterior part of the heart. So the inferior leads are lead 2, 3, and AVF.
Okay.
So once you have ECG changes in this area, that's inferior infarction, and it's due to obstruction of the right coronary artery. Lead V1 to V4 is the anteroseptal leads, and it's due to affectation of the left anterior descending artery. V5, V6, lead 1, and AVL, those are lateral leads and are mostly due to obstruction of the left circumflex artery. And posterior leads, you might actually not see anything on your ECG, but if you are able to extend your ECG leads to the back, so you put a lead 7, lead 8, lead 9, you might actually be able to see that. But sometimes on the normal ECG, you may see a reciprocal change in the anteroceptal lead, the V1, V2, V3. You can have S7 depression. So like a mirror image of what is happening, and that is usually due to left circumflex because it also supplies most of the posterior parts.
We're running out of time. I'll just ask us we'll discuss some of these biomarkers. We'll talk about troponin earlier on, and I think it's the most commonly done biomarker for for acute myocardial infarction. Of course, I think we just focus on that. There was someone that was referred, I think, from Akwa Ibom that we saw earlier today. He came with CKMB as well. CKMB as well. So, but you should know that apart from the troponin, which is the most widely used serum biomarker for ischemic heart disease, we also do use CKMB. There's a role for using CK in some settings, and myoglobin can also be used. And all of these ones, they actually have their timing. So myoglobin is often the first one to get elevated, and then the troponin actually lasts much longer compared to the other ones. Okay, but troponin is perhaps the most specific because we know that we can find myoglobin in the muscle. CK, if it's a general CK, you can find it in many places, including the muscle. But if it's a CKMB, it's fairly muscle specific as well. But troponin is still the most widely recommended and the most widely used biomarker for myocardial damage. So apart from the ECG that we mentioned, the troponin, and perhaps which other investigations are necessary for these patients?
So other investigation you want to do is an echocardiography.
Okay.
Echocardiography can help you to establish your diagnosis where you can identify motion abnormality of the heart.
Okay.
Because once an area is affected, the motion is affected.
Okay.
So you can either have a reduced motion.
Okay.
You can also have areas that are not moving at all.
Okay.
Or areas that are moving in the opposite direction.
So the echo can help us, even though very acutely there may be not enough time to do the echo. So apart from the echocardiography, which other investigations are useful in this patient?
Other investigation is looking for other cardiovascular risk factors like we talked about, cholesterol, your blood sugar. You want to find out the clotting picture of the patient. We talked about chest X-ray because, like I said, other equally life-threatening condition like aortic dissection that will also present this way. So it makes this important.
And that means that this list is not exhaustive because the differential diagnosis of chest pain is actually quite very broad. So talking about still that differential diagnosis now, apart from myocardial infarction, a patient presenting with chest pain, which other differential diagnosis can we consider? You already mentioned aortic dissection now. Which other differential diagnosis can we consider?
I'll just mention the one that I said that are also equally life-threatening, like myocardial infarction. So I talked about aortic dissection. The patient may actually be having a pulmonary embolism. And if you remember, the patient we presented had elevated D-dimer. But we should note that D-dimer can also be elevated in other disease conditions apart from pulmonary embolism. Patients could have acute pericarditis, even cardiac tamponade from pericardial effusion. So we should also note this. And these are other life-threatening conditions. Then also esophageal rupture is another life-threatening thing that we should consider. And patients will present with retrosinus chest pain that could also get better with nitroglycerin. Then other less life-threatening condition, costochondritis.
I think we're running out of time. Let's take the third poll, please. The third poll and the final poll for this session of the presentation. We should remember to put our questions in the Q&A box. We'll address them later. It makes the presentation richer, actually. Okay, so this poll is being launched now. The question states that in the 49-year-old man that was admitted with chest pain, the pain score was still 10/10 1 hour after admission, despite paracetamol that was administered. The ECG showed ST elevation in the lateral leads, and the troponin was very high. His blood pressure was 122/100, and the pulse was 119 per minute, which is correct. Which is correct. Which is correct. Participate. Which is correct. Okay, I think we've had enough. Thank you. Thank you for participating. Again, Dr. Olalekan, what do you think?
Okay, so this is a patient with myocardial infarction, ST segment elevated myocardial infarction. You've seen the BP, the pulse. So which is correct? The pain should be optimized by giving intramuscular diclofenac. This is now talking about the general measures that we must quickly do in this patient. Number one is to control the pain and reduce the extent of ischemia. And one of the key things to do for this patient is to control the pain using opioid analgesic.
Okay.
Morphine.
Okay. So diclofenac won't be a very good idea.
Diclofenac will not be a good idea in this patient. Number two, nitrates are contraindicated in patients with tachycardia. Nitrate is one of the other things. So we have this common acronym MONA.
Okay.
Morphine, oxygen, nitrates, and aspirin.
Okay.
So we talked about morphine. Morphine reduces the pain, also helps to relieve the anxiety. And by the time you reduce the pain, you reduce the anxiety, even the pulse comes down, the work rate of the heart comes down, the myocardial oxygen demand comes down, and the patient, the extent of ischemia also comes down.
So what is the main contraindication we have to nitrates?
Nitrate is contraindicated in patient that has hypertension.
Absolutely.
Patient that has right ventricular infarction, that is patient that has inferior MI due to right coronary artery, and patient that has just taken sildenafil within the last 24 hours.
Absolutely. So those are the main
contraindications to nitrate. Aspirin is essential. Okay. Even if the patient has the worst history of dyspepsia, with that you can do your aspirin still under proton pump inhibitor cover. And early coronary angiography, that is just the key. The earlier you can do this, the best for the patient, both short-term and long-term outcome of the patients.
Okay, thank you for participating in that poll. I hope that we're all picking bits and bits from it. So how do we manage? We're out of time, unfortunately, and I don't like it when we're out of time to just talk about management, but we need to talk about management.
We need to talk about that. Like
absolutely.
The quick general measure: assess your oxygen.
Yes.
If SpO2 is less than 90%, put the patient on oxygen. If the oxygen saturation is normal, you don't need oxygen. Oxygen actually causes coronary vessel constriction in patients with normal SpO2. So giving that is counterproductive. So after oxygen, you should give this patient aspirin, because going through the pathophysiology, we talked about platelet aggregation, thrombus formation, so they need anticoagulant and antiplatelet. So you give this patient aspirin. So first, give this patient, we're using 75, 150, give the patient 300 milligrams of aspirin to chew, not to swallow. Chewing help us to increase the buccal absorption of the aspirin. That is the idea behind chewing it. So if the patient swallow it, you have to wait for the party, whatever. But by the time the patient chew it, it improves buccal absorption of the drugs. Then after that, we talked about relieving the pain using your morphine. Then for some people, after morphine, they may have nausea and vomiting. You may need to give some antiemetic. Then give your nitrates. What will nitrates do? Help you to dilate the coronary vessel, improve oxygenation, and you can either do a sublingual nitroglycerin, you can use spray, and if you have the IV, you can also do this. So these are the quick measures you must quickly do. And as you are doing this, you are doing your ECG, you are doing your troponin, and hopefully maybe before you finish this, you are seeing and you transfer as fast as possible. A center where they can do the PCI, you want to do that within 90 minutes.
Absolutely, for the best outcome.
For the best outcome of the patient.
There's a patient we managed recently that the PCI, because of transfer, logistic, and maybe a bit of financial issues, the PCI it took up to 24 hours before the patient was transferred and they could get a PCI done. And the patient has some heart failure symptoms now, which is actually, and that heart failure symptoms is likely going to be long-term actually, which can totally almost be entirely prevented by acting very, very, very early. So I think that it's important that you mentioned that. Now, how does the management of NSTEMI differ from that of STEMI?
Okay, thank you very much. That is why it is good to have that ECG, because for patients with ST segment elevated MI, if you cannot do you don't have access to a Cathlab and you have thrombolytic agents that you can use,
okay,
that is another option that can be tried if there is no contraindication and if the patient presents within the acceptable time window. But for a patient with non-ST segment elevated myocardial infarction, the key to their management is the general measure we talked about and other treatments that offer both short and long-term benefits in terms of beta blocker, ACE or angiotensin converter enzyme inhibitor or ARB.
Okay.
But thrombolysis is 100% contraindicated in patients with N-STEMI.
Absolutely.
You don't do thrombolysis. So if the patient has maybe cardiogenic shock, heart failure, the patient is not improving after giving all this general measure, in N-STEMI, you have to take the patient to Cathlab for intervention. You should not do thrombolysis in them.
Okay, thank you very much for highlighting that. So in terms of thrombolysis versus PCI, okay, so just for restating it again, thrombolysis is using thrombolytic agents like tenecteplase and alteplase to burst the clot. Okay, it doesn't do anything to the plaque there, but the clot that is just acutely causing something. So it's something that can be done acutely pending when someone can get PCI done. Okay, and that's what we call like secondary PCI. But primary PCI is when the person gets PCI straight when the person has a heart attack. So how would you compare these two approaches, opting for thrombolysis or trying to get PCI in terms of treatment of myocardial infarction?
All randomized control trials experience have shown that the patients that had primary PCI had a better short and long-term prognosis than thrombolysis, because like the moderator said, you are not only removing the clots,
okay,
you are removing the plaque and you are putting a stent to keep
that place
open. So you are helping the patient a lot to salvage as much myocardium as possible, and if that can be done timely, you have done a lot of good to the patient, because your thrombolysis, apart from the complications, it could fail.
Okay.
And you now have to still go for a secondary or a rescue PCI. So PCI offers better outcome for patients with heart attack.
Okay, so let's say a patient had a heart attack and the heart attack either was not recognized or was not well managed, so to say. But let's say it was not recognized, for example. What are the possible consequences of this?
Depending on the vessels, the coronary vessel that is affected, the extent of the injury, a lot of complication can come up. Number one, patient can have different types of rhythm abnormality of the heart. For example, in a patient with right coronary artery obstruction, which supplies the AV node and all the other electrical pathway, patient can present with different type of AV blocks, high degree AV block, complete AV block.
Yes.
Then, looking at the left anterior descending artery that supplies the anterior aspect, you can have ischemia of the mitral valve apparatus, so the patient can actually present with mitral valve problem. Patient can have some ventricular septal defect from affectation of this. A patient can actually have what we call pseudo aneurysm or aneurysm due to damage to the free wall. A lot of things can happen.
So basically, if a patient has an acute myocardial infarction and the patient does not get the kind of treatment that should have been given for whatever reason, so you mentioned that there is a lot of arrhythmias that can lead to sudden death. They can have complications, and of course, they can progress to heart failure, either acutely or even chronically. And these are all things that are not something that we wish for
at all. And we can see from the recent happening, they talk about Maradona. A lot of people, one new said he died of heart attack, another said he died of cardiac arrest, and this is a common mistake that people usually make. Heart attack is different from cardiac arrest. Heart attack is a circulation problem or a pipe problem.
Within the heart.
Cardiac arrest is due to an electrical problem that can lead to sudden cardiac death, but they are also connected because heart attack can cause cardiac arrest.
But someone can have cardiac arrest without an heart attack. So, which of the thrombolytic agents are locally available in the country before we go to the complications?
The very old one, our streptokinase, is still there with a lot of problem. Then, I think we've used Alteplase here recently.
And I know I've met some of the marketers of Tenecteplase, so that's I think we have 1 or 2 thousand.
Yes, and the patients did extremely well, and that was before our Cathlab.
Okay, so would you summarize the complication of myocardial infarction for us, perhaps on one slide?
I will summarize the complication into mechanical complication.
Okay.
Breathing complication.
Okay.
Reading, I talked about different type of arrhythmia that can come up. They can have AV block, ventricular tachycardia, ventricular fibrillation, atrial fibrillation, due to different causes. Then mechanical problem, like you said, due to affectation of valvular apparatus, affectation of the free wall of the ventricle, affectation of the ventricular septum. You can have different complications, ranging from ventricular septal defects to
complications like
cardiac tamponade due to the affectation of the free wall. You can have aneurysm, pseudoaneurysm. If an extensive part of the myocardium is involved, the patient can actually go straight into heart failure and cardiogenic shock due to motion abnormality of different parts of the heart. The heart is not beating well as a unit. You have clots that can form. Patient can have stroke from that. So,
Dr. Olalekan, we're out of time. We're really out of time. So I think I'll just, in a bit, before we go to the questions, I'll just summarize the key things you've said in the management of acute myocardial infarction. You've told us that, number one, we should have a low threshold of suspicion for diagnosis. For patients with chest pain, we should do an ECG very early, okay? And then subsequently, you went to tell us that in the management, of course, part of the evaluation, apart from doing the other things, is important to be able to do a troponin, because sometimes the ECG changes may not be that clear-cut, may not be that as specific as we wanted it to be. And in terms of management, you did mention that the patient should be given usually opioid analgesic like morphine for the pain control. The patient should be on oxygen, especially if the SpO2 is less than 90. We should give nitrates, particularly GTNs, which can be given as a spray under the tongue, or the isosorbide dinitrate or the GTN tablet. The main contraindications to it is if the person is hypotensive, you may be wary of giving it. But otherwise, the patient should have it. And the aspirin should be chewed, not sublingual, not just swallowed, but the patient should literally chew the aspirin, which should be between the dose of 150 to 300 milligrams. And of course, even though thrombolysis can be an option in very, very limited situations, the patient is always better on with a percutaneous coronary intervention. Okay, thank you very much, Dr. Olalekan. Can we now start to take the questions in the Q&A box? So someone says that, just to be clear, stable angina is an ischemic heart disease, but not an acute coronary syndrome. Absolutely correct.
Yes, absolutely correct.
Okay, so how does respiratory infections cause myocardial infection? Very interesting.
How does respiratory infection
cause myocardial infection?
Infection directly from the chest. But like we know, as part of the infection, like for example, COVID, you can also have a myocarditis.
Absolutely.
And also vasculitis.
Absolutely.
So going through that pathway.
Okay. So there are two possibilities you mentioned. And you mentioned about the fact that the heart and lungs are almost continuous with each other, and there can be contiguous spread. And then there can also be hematogenous spread in form of bacteremia and those kinds. So those are just the two main pathways. Of course, most of the time, the way a respiratory tract infection will lead to a myocarditis often is through mild pericarditis, such that both the pericardium and the myocardium are involved. Someone said that can IV-based drugs like paracetamol cause fat embolism that leads to MI? What do you think about that? Can paracetamol cause fat embolism that leads to MI?
That leads to MI.
Not to my knowledge.
Not.
But fat embolism from any cause, depending on what part of the circulation is happening. If it's from the venous circulation, which is a common pathway usually will lead to pulmonary embolism, pulmonary fat embolism,
not
except
coronary,
except if it's except if there's a patent foramen ovale that will cause that. Okay, so someone says if someone develops acute myocardial infarction at home, are there immediate measures the patient or family members can institute before getting to the hospital? I don't know what Dr. Olalekan will say to this, but Dr. I will say that they should get the patient to the hospital as soon as possible.
That's what I want to say, that the first measure is to get the patient to the hospital as fast as possible.
Now, there's been some circulating videos that said that if you take a deep breath or if you cough and all those things, those are not evidence-based. It's possible people can do different things in desperate situations, but the truth is that there's no evidence that suggests that anything of sort like that.
Then you can say maybe for people that are medically inclined, or if you have aspirin at home,
absolutely.
You can quickly
chew that
while trying to get
and that will help to some extent. Okay, so someone says that what's the best fluid to give a patient presenting with MI, Dr. Olalekan?
Best fluid to give. You can actually see that when we were talking, we didn't mention fluid. Fluid therapy is not needed, part of the key things you need to do. But if you need to give fluid based on other compelling indication, you will determine what you need to give. For example, we talked about random blood sugar. If the patient has hypoglycemia,
absolutely,
your dextrose saline, dextrose water, but fluid therapy is not one of the key things in the management.
Now, sometimes someone with an inferior MI might be hypotensive enough to need fluid sometimes, but usually most patients with acute MI would probably not need IV fluid. Now, how do we read troponin results? So troponin results depends on the lab usually. The labs, yes. So some are just qualitative tests, that is just tell you positive or negative. Okay, the one we do in Cardiocare is a quantitative test, and it gives you the amount, and that amount can actually in most of the quantitative tests, the normal should not be detectable, and usually they just give less than something. So in our lab, for example, is less than 50. That's the normal range. Anything greater than 50 is significant. Of course, the higher it is, the more significant it is, but it's significant. So anybody with 100, there's some myocardial necrosis going on. Don't forget that troponin is act specific. It's not really found anywhere significantly else in the body. Okay, so someone asked that how can ECG differentiate MI from acute pericarditis?
Okay, thank you very much. That's one of the things we didn't mention due to time. The ST segment morphology is what you want to look at.
Absolutely.
And we'll talk more about this tomorrow. In pericarditis, the ST segment is elevated, but the pattern is concave. It's like a spoon-shaped elevation of the segment. And if you now turn the spoon the other way around, like the horseback or like a tombstone, that's what you have in pericarditis, in heart attack, because the person is dying, so he's showing the tomb, so you have to do something very fast.
Okay, so can clopidogrel be an alternative to aspirin here in MI?
We actually need the two.
Absolutely.
Most of the time, we need dual antiplatelet for them, so you give them both the clopidogrel and the aspirin.
So studies have shown that that is very, very, very effective for it. What if morphine is not readily available? Are there any other drugs that can be used as substitutes?
Give any analgesic that you have. If you don't have morphine, don't say because I don't have morphine. If you have pentazocine, tramadol, and there is no contraindication to its use in that patient, please give that. If it's paracetamol you have, just try and reduce the pain, because like we say, the pain increases anxiety, tachycardia, places a lot of burden on the myocardium. So just do anything to make sure that you reduce the patient's pain.
Why are nitrates contraindicated in patients who have recently had sildenafil?
Because of their vasodilatory effect, so they cause severe hypertension.
Absolutely.
And for a patient that is already having some oxygen demand supply, so especially in people with right ventricular infarction, if you do that, you worsen the patient's condition. Okay,
so here's a question that says that had a patient who presented with sharp retrosternal pain, was restless and holding her chest. Angina pectoris MI was suspected to rule out acute PUD. Later got the history of the complaint starting after the patient read through her husband's phone. Was any of the diagnosis above correct? Okay, so I think I would like to answer that. So what I would say is that anxiety and psychologically related issues, number one, can cause a lot of chest pain and symptoms. Okay, but this is almost a diagnosis of exclusion, and you should have ruled out life-threatening causes of chest pain. Don't forget that acute myocardial infarction can be precipitated by emotional stressors, bad news, finding out something bad, your husband is cheating on you or something like that. So those kind of things can precipitate a heart attack in someone with coronary artery disease. So I won't say any of the diagnosis is right or wrong, okay, but I will say that emotional stress can precipitate an myocardial infarction. Emotional stress too can worsen peptic ulcer disease. It's there in Oxford Handbook of Medicine. So psychological stress can worsen peptic ulcer disease. And I would also want to add that psychological issues sometimes can cause chest pain, but we should not just attribute it to that without thoroughly evaluating such patients. Is there an upper limit for PCI? And then can you highlight the contraindications to thrombolysis?
Okay, we talked about timing being of essence. The goal is to get your PCI and get it done within 90 minutes
Absolutely.
from the time of symptom. But if you cannot achieve that, as long as you have evidence of ongoing ischemia, do your PCI to save the patient. Don't say because you have missed the 90 minutes, let me leave.
In fact, even if there is no ongoing ischemia, once there is, if we thought that the vessel was blocked to some extent, even if there was some recanalization, the patient still needs to have an angiography because that recanalization will fail one day. So that means there's some extent of blockage at that time. So even some people that their myocardial infarction was 2 months ago, maybe they were somewhere where they didn't have access to treatment and they've apparently recovered from it, they still have the QA. It's still good for them to have a coronary angio so that they can identify any blockage that's still there, even if it's a chronic total occlusion. Okay, but for acute MI, like Dr. Olalekan said, the best outcomes is obtained when you get when the PCI is done within 90 minutes, as soon as possible, but within 90 minutes. And that is the standard they hold many hospitals accountable to in the Western world.
So someone asked a question about what is called MINOCA. That is myocardial infarction with non-obstructive coronary artery. Oh, yeah. Like we talked about that, there can be this presentation which in the absence of arteriosclerosis or obstruction. An example is in a patient with vasospasm, metal angina. Most of these patients are young, and by the time you take them to Cathlab, the vessel is clean. The management, the general management is virtually the same, but we have to emphasize the use of vasodilatory agents in this group of patients, our nicorandil, Vasarel, nitrate, but is an entity that we need to.
Okay, so someone asked that can you highlight some of the contraindications to thrombolysis? I know it's massive, but just mention the key ones.
There are many.
Just mention the key ones, sir.
Recent hemorrhagic stroke.
Absolutely.
Recent use of streptokinase.
Absolutely.
Severely elevated blood pressure. Some end organ damage. Head injury.
Previous history of hemorrhagic stroke at any time. Puncture in non-compressible sites. So those things that will increase our risk of bleeding or blood loss.
By the time you get this slide, you will see the exhaustive.
So that's fine. And then someone mentioned that what complications should we expect if you thrombolize somebody? What are the notable complications of thrombolysis?
Number one, like you said, is bleeding.
It's bleeding. And it can be torrential.
It can be fatal and torrential. Then for a patient that has taken streptokinase, you don't know, that will be severe reaction. So at least those are highly recognized side effect or complication of thrombolysis.
Okay, let's take the next question, please. So someone is asking that. How can someone identify ectopic bits on examination?
That's starting from your examination of the pulse, like we're taught in medical school. In pulse, what do you want to see? You want to look at the rates, you want to look at the reading, you want to look at volume, you want to look at synchronicity.
Absolutely.
So when you look at the reading, that is where you know whether the patient has
ectopics.
Normal.
So if it's following 1 2 1 2 1 2, it's probably regular. But if you are getting 1 2 1 2 1 2 1 boom, so those are ectopics. Of course, we say a pulse can be regular, it can be regularly irregular, or it can be irregularly irregular. So Ideally, the one we refer to as ectopics is the one that you get the extra bits on the background of regular bits. So those are ectopics. And on the ECG, there are actually PVCs and APCs. That's premature ventricular and atrial contractions. Okay, thank you very much, Dr. Olalekan, this afternoon. I think we've had a wonderful discussion, and I'm happy that the audience followed. Thank you very much for participating in the polls. And shortly, we'll be taking the next topic. I know that we've used your time a lot this afternoon, and we will be very brief with the next session so that we don't take so much of our time. But before we go for the next session, we'll still take a few minutes break. So I'll encourage us to hold on just for a few minutes, less than 5 minutes. In 2 or 3 minutes, we will be back line. So just hold on.
I will encourage people to participate, as in to be around for the next session. It will be some of the things we discussed. You will see in real life how some of these things were tackled and such.
Yes, sir. Thank you very much.
All right, good afternoon, everyone. This will not last very long, so prepare for tomorrow. This is ACS 2020. Thank you very much. My name is Dr. Iseko. With me is Dr. Awofisoye again. Dr. Awofisoye is the Medical Director of Cardiocare Hospital. ACS is brought to you by Cardiocare Hospital, essentially. Cardiocare Hospital was launched yesterday, actually in Abuja, and we've had quite a great time in the process. So what's going to happen now, I'm just going to try and show you what the Cathlab looks like, and I'm going to take questions and then we'll answer it from there. We are actually in the middle of a case now, so I just have to run downstairs to take it. So let me
okay, so while you're showing that picture, basically, we're talking minimally invasive procedures that are related to the heart's function, and we have quite a few of them. I'm sure that our audience is familiar with a few of them. This afternoon, we've already mentioned PCI. We use the term PCI quite a number of times. Dr. Olalekan did mention coronary angiography, and those are part of the things that are common, little common things that are done in the coronary, in the Cathlab rather. So we mentioned PCI, which is percutaneous coronary intervention. Even though that term, we often do actually say that term so much air, but it actually involves having a coronary angiography and then having a coronary angioplasty, which in the past, coronary angioplasty used to be just using a balloon to widen the place. But in the last several years, more than a decade actually, it has involved using a metallic mesh that we call a stent, right?
Yeah.
That we call a stent, which can either be drug-eluting or plain stents. But almost all the stents we use here are drug-eluting stents, right?
Yeah, exactly. So essentially what happens in the Cathlab, and it could be elective or emergency for coronary artery disease. Essentially, a wire is put in through the femoral artery. So you just take a needle, we puncture the femoral artery.
Absolutely.
And put in a wire, and pass that wire straight to the heart. Now, those wires are specially designed, and they have their names after the people that designed them. Judkins left, Judkins right. That's what we call it, JL or JR. The wires are designed such that they go into the aorta and sit directly on the aorta. Okay, so I'm trying to share my slides and having some slide size too big. So they sit directly on the aortic wall and then anchored into the origin of the coronary arteries. So essentially you have a wire, something like this, and the wire is, you pass the wire straight, followed with your catheter, get to the aortic arc under fluoroscopic guidance, and that's what a Cathlab is. A Cathlab is really a big fluoroscopic guidance. The patient is typically awake. What we do is that we give mild sedation, Lexotan 1.5 milligrams. We give some loratadine for allergies, and then we pass the wire straight into the heart, into and aortic arc, and we'll engage the coronary arteries on the left or on the right. So we'll do the left first or the right, depending on who is the person operator. And at that point in time, we typically will give dye and take it from there.
Okay, absolutely. So that's talking about one of the most commonly done Cathlab procedures, which is one of the most commonly done minimally invasive heart disease. So what you talked about now is the coronary angiography, which has to be done before any form of angioplasty or stenting is done. Before we go on, I also want to mention the other common minimally invasive cardiac procedures that are done, most of which are done here. So, of course, we'll talk later about pacemaker insertion, about the insertion of devices for the heart, including the ICD, that's the implantable cardiac defibrillator, and the CRT, which is what we call the cardiac resynchronization therapy. Of course, there are still many other minimally invasive cardiac procedures that are done. There is measurement of the right and left heart pressures by what we usually call it right heart catheterization, and that's often done for children who have congenital heart disease. And those congenital heart disease are often enough to cause various problems for a child. Apart from that, we know that many valves can be repaired through a minimally invasive cardiac procedures. Many valvuloplasties can be done, and I'm not sure whether we are familiar with this term called TAVI. That's
transcutaneous aortic
valve replacement, something like that. So that's TAVI. It's not yet really done in Nigeria, but for frail patients who cannot withstand this traditional open heart aortic valve replacement, they have that done as well. So these are some of the spectrum of the minimally invasive heart procedures that are described, and all these things have to be done in a cath lab. You literally cannot do them outside the cath lab. So when someone has an angiography, what are the possibilities? If someone has a coronary angiography, do you have to stent the person? One, are you always going to be able to stent the person? Two, and then what proportion of people that have coronary angiography require stents?
So essentially, a lot of people require a stent.
Okay.
In Nigeria, what we have seen so far, so in Cardiocare, we have done over 70, 80 cases. Yeah. What we have seen is about a third of patients require some form of intervention, or at least we can intervene in. And several possibilities happen after the angiography. Number one is that you go in and you see a blockage in one of the coronary vessels, one or more of the coronary vessels, which may or may not be clinically significant.
Okay.
So typically we determine clinical significance significance of a lesion by several methods. One of them is to determine it by the caliber of reduction of the vessel. And so anything above 60% is considered to be significant, and typically you would decide to intervene on it. Also determine it by the type of vessel. So some vessels are closer to the origin, LAD, left main, and that those will now tell you how significant it is. Thirdly, we can define it by using a special intravascular ultrasound. So through that same probe or catheter, you deploy a wire that has at the end of it a transducer, and you kind of tell the thickness of the intima. The other way we do is through what we call an FFR. Through what we call an FFR. Okay, so through what we call an FFR. An FFR essentially is a special machine whereby we try and determine the fractional flow reserve. So there are actually two types, IFR and FFR. And so we use the machine to determine how much of flow is left. So we try and determine that and how clinically significant is there. Now, having determined this, the question now is to ask yourself whether it is possible to intervene or to revert to surgery. And that depends on the risk of intervention. How risky is it to intervene or not?
Okay, so thank you for highlighting those parts of it. So basically, someone that has coronary angiography, they come out with a stent, and that third dimension, it also depends on your criteria or how stringent are you before you take a patient to cath lab. Typically in the Western world, any chest pain that is just not very clear, they go to the cath lab. And for most of them, the proportion of patients that need intervention is probably maybe 10% or even 20%. Okay, but in Nigeria, for someone to go to Cathlab, many times people wait until things are very bad or they've had a gross heart attack before, and it doesn't actually necessarily need to be like that. So, of course, here are some pictures that we can see of the Cathlab, and each fluoroscopy machine is there. The pressure bags are there, which we are going to talk about along the line. So, in addition to the coronary angiography, we also do angiography can also be done peripherally, actually. So, for people with peripheral arterial disease, even though strictly speaking that will not qualify for a heart stop, but for people with peripheral arterial disease, which can manifest with either intermittent claudication, that's pain after walking for a while, okay, or features trophic changes, cold extremities, airless extremities, or with the frank gangrene of the foot, that can actually be someone that will need such a procedure.
Exactly. So if you look on the screen now, what you are seeing essentially is a coronary angio. I will just pause. I will just pause. Now you can see this wire.
Okay.
You can see that wire. It goes all the way. We have passed it from the groin, and
Okay.
sometimes we can do it from the radial artery.
Okay.
So we have passed it from the groin, and so you can see the wire. We have passed it from the groin. It has come all the way, and it has a special curve. This is the primary curve, and this is the secondary curve, and it just hooks directly. This is a Judkins left catheter. The distance between this point and this point is how we use to size it. So that helps tell the size of the aorta. So typically this looks like a 3 Judkins JL 3.0, goes in, hooks here, and then this serves as some form of rest where it can, like a where it can anchor. Now that hooks, and then we turn it until it engages the coronary artery. When that happens, we now, at that point in time, we put a dye and give a dye. Typically, we use, the special dye for coronary, not the ones that we use for HSG or CT scan. So by the time you give the dye, what you now get is what you are looking at. You can see the area of blood flow. You can see it. And here you have vessels branching off. I will not labor you with all the names and all of that. But you can see vessels branching off. Now you can see this vessel. As you can see here, you can see how big the vessel is. Yes. And you can see what is happening here, how narrow it is.
Interesting.
So this is essentially where the blockage is. And you can see the blockage is almost from here all the way down here. Okay?
Move the red away from it so that they will actually see the narrowing very well. Absolutely.
Yeah, so that's essentially is what you are seeing here. So this is a blocked proximal LED, and you have that. So what we do essentially is to, after we have seen this, we remove this wire. Okay. We then pass another type of wire that allows us now to intervene. Okay, these are quite expensive, so intervention is a little bit expensive. So in that wire now, we now pass a wire across the
narrowed area.
Around the narrowed area. Of course, you can see this area looks a little bit bigger than this area, the area distal. That's because all the pressure coming from the aorta is stopped here. So this starts dilating, and this looks narrower, but just because it's not getting enough blood flow. So this is about almost 95% occluded. So what we now do is to pass the wire first, then over the wire we now pass our stent or our balloon and try and anchor it here and here. Then we inflate it. After inflating it, the stent is left behind and deploys into that space. So that essentially is what you can see.
Interesting, very, very interesting. And I mean, looking at this just shows the clarity. And the thing is that if there's this kind of narrowing, is there any other thing that can treat this kind of narrowing without actually passing something through the coronary arteries?
So what is blocked is blocked. What is blocked is blocked. Except the person is coming, like Dr. Olalekan already said, come very early and you're able to institute thrombolysis. By the time it has blocked, it has organized. So even if you give a thrombus block buster, a clot buster, it cannot break it. So it has organized, it has formed, fibrin has formed around it.
Absolutely.
So essentially something must come here. It's either you put a stent or you go and do a coronary artery bypass. But typically for something like this, we easily will do that in Cardiocare and most other cath labs that are available to do so. So patients typically they're having chest pain. Sometimes you even have almost a normal ECG, and this is what we find inside their hearts. So I will just pause for a moment and show you some of the wires that we use. So this is a sheet. This is a sheet, the 6 French sheet, like you can see. And essentially, when you get the femoral artery, you put your fingers over the femoral artery, you can feel the pulsation, you put a needle in, and then it starts shooting out. Then you put this over the needle. I mean, you put the needle in, then you get a wire. Then we don't have a wire here. We pass the wire into the femoral artery, remove the needle. Great. At that point in time, just like doing femoral cannulation for dialysis. Then we put this over the wire and put it inside. Then we remove the wire, and this is here. Now, this sheet has a valve right here, this green area. So it has a valve there. So once we put this in, it doesn't allow blood to shoot out. So essentially, through this is now how we now operate. So, okay. So that's essentially how we now operate it. So that's essentially how we now operate it. Now we'll now take this, as we are looking at this, and this is a JL wire for the left coronary artery. And you can see how the hook is, just like I showed you in that slide. We now put it into this, of course, after putting a guide wire. So put a guide wire inside this, and then we put this into it, and then we pass it all the way up into the coronary vasculature.
These wires are quite long. I mean, for it to get from the groin to the...
Exactly, and we can also use them. So this is left, this is right. Now we now get there, and you now see what we're talking about. So these things can be done very easily here in Nigeria, and it's no longer something that people will be traveling abroad as if, you know, there's nothing in this country. So this is essentially what it looks like.
Very, very interesting. Comparing coronary to peripheral angiographies, which is typically easier to do.
So coronary, I don't know. Coronary is typically what you have been doing, so
okay,
we have
that's what people are more used to.
But
I want to almost imagine that the peripheral may be more easily accessible, but the truth is that they are not often done because the coronary artery problem is actually a much more intense and common problem.
So what we are looking at on the screen now is what we call a CRT. So for patients with advanced heart failure, we'll talk about this on the first day of the ACS by Cardiocare. This was a procedure done here in Cardiocare. We put in leads. This is a lead we put into the right ventricle, we put a lead into the left ventricle, and this other catheter, we are trying to put a lead will supply the left, this is for the right ventricle, that will supply the left ventricle, this is right atrium, right ventricle, and we're trying to put in a lead. This is to try and get the coronary sinus. So we're trying to get the coronary sinus in this video. Put this, then we pass a third lead into the heart, and that way it helps hearts that are having abnormalities to be able to function a little bit better. So this is essentially what it looks like. I will show you inside the Cathlab. So this is what our Cathlab looks like. This is our entrance, and you can see there is a biometric lock just to make sure that it's only authorized people that can go in, or with a code. You can see the red line. This is the OR changing room. Essentially, this is how you go in to get into the Cathlab. We change there. We also gist there. Sometimes you have a quick snack in between procedures. And there's also a toilet there for in case we need to use. And then this is the corridor. You notice that the entire floor has an antibacterial floor. There are no lines. There are no this thing. It's specially prepared for antibacterial. And this, of course, is a scrub area. So because you need to keep aseptic. This is the cardiac theater. So occasionally you might run into trouble in the cath lab, and you may have to go into the theater. Okay, so you will have to be prepared for that as well. Okay, so so you have to be prepared for that as well. And so that's why you have the cardiac theater next there. So this is what the cardiac theater looks like. Some things this is an old video. There are a lot of things here, and of course we have automated things to do that. So this is the ICU, and I will show you the cath lab. So this is the cath lab. Now you notice in the cath lab, you must have a defibrillator. And in every hospital, I would advise you, since you are here for ACS, when we are talking about BLS tomorrow, BLS will start by 1 o'clock. People on site will be here, but we'll also stream it live. So if you are able to join by 1 o'clock, great. Otherwise, if you join by 4, we will just start normally by 4. I'll be teaching BLS with the other consultants here in Cardiocare. And you will see this is a full-fledged defibrillator. So ready for emergencies. You must have a ready crash cart in case of problems, because a lot of problems can happen in the cath lab. Okay, so this is with the paddles, and sometimes we have to use paddles, and sometimes we have to stick on. Occasionally, you have to adjust the voltage, especially if you are doing cardioversion or defibrillation. Okay, you have your crash cart there. So these are the components of a cath lab that is here. Okay. So those are some things that you need to, of course, you can see the defibrillator charging and all of that. Okay, and you have to have a checklist to check all of that. Now, these are the multiple wires, and I told you about, we have to have because you don't know what size you will meet inside the patient. And so this is essentially what it looks like. You know, so I had never seen a cath lab until I almost became a consultant. So I'm sure I was showing all of you this for free. So you have traveled abroad right now here to Abuja. And these are the stents we're talking about. You can see the stents have different sizes and different lengths. These are balloons, the NC balloons, non-compliant balloons that are used in the cath lab. Okay. So we've done, this was about 2 months ago. This was figures about 2 months ago. Now we've done over 70 or 80. We had done about 45 angios, and out of them, 35.6% were positive, and 4 were referred for surgical intervention because it was too difficult. I mean, it was not suitable for angios, or the benefit outweighs the risk. So, and then we put in devices, of which CRTD, we put in much more CRTDs now. So it's a little bit better. I think our video has gone off, unfortunately. So, of course, had some complications occasionally, which can happen. So sometimes we have to stop the procedure, treat, and come back at a later day. One of the patients developed severe hallucinations, and we had to stop. Sometimes some patients stop cooperating, we had to stop. And then there's a near miss. Occasionally, people can come with what looks like cardiac arrest, but really what is really happening is that they're having COVID. And we had that near miss, turned out to be COVID. Our procedure was not done. He was referred to a treatment center. Of course, we are in the process of training, and that's what we are doing here, pre-cardio care, intra-cardio care. Right now, we have residents and consultants upstairs in the lab as we are doing. This was last year, if you remember, but now, this year, we are here doing it online, and it's something that we have been doing. So if you look at the picture here, this is still our cath lab. If you look at the picture there, and you can see the intervention cardiologist, assistants, residents,
and the Cathlab technologists.
Cathlab technologists, monitors for the patient. This is the cath lab. It's a big C-arm, and you are really watching as you are doing it. You're also looking at the screen. The patient is typically awake, and then of course that's what we have to.
Checking the arterial pressures, the ACT, that's activated
exactly.
Clotting time.
So clotting can change because we have to stop blood from clotting. We have to give drugs to stop the clotting. Unfortunately, our video is off, so sorry about that. We'll try and see how we can fix it.
So in addition to that, I would still just want to mention a few things about pacemakers. Many patients that require pacemakers and heart devices like ICDs actually don't get them. And a lot of factors contribute to this, and I think those are the last aspects of the minimally invasive cardiac procedures that we need to talk about. So the pacemakers is indicated for people who have bradycardia, especially when it is a symptomatic bradycardia. CRT that we have mentioned earlier, actually, if you're looking at the devices, they look not so seriously different from a pacemaker device. And the wires also go through the veins of the neck into the into the heart itself, and the device is usually placed under the right clavicle.
So
okay.
let me just butt in there. Now, if you look at this device is what we use when we are putting a pacemaker. The device is used to interrogate the pacemaker and to program the pacemaker. So essentially, that device is what we use to make sure that we are able to program the pacemaker and and then pick it up like how you see it. So after we put the pacemaker, what we do is that we put the pacemaker under the clavicle on the right, and then we connect those wires that I showed you. We connect those wires into the heart. Let me show you again. Yes, so these wires are connected into the heart. They are screwed into the myocardial heart muscle, and the wires are connected. And then the pacemaker is put under the skin, and it's typically inert and can last up to 5 years. Okay, so we're running out of time, so we'll probably have to start cutting short. I will just take a few questions, and then tomorrow we'll continue because we have from 1 o'clock. Okay. Can the stent dislodge in the process of time? Typically, no. The stent does not dislodge, it stays there. It occasionally gets embedded into the wall, especially for the bare metal stents. But most of the stents we use that drug reluting, it doesn't get dislodged, it opens, it stays there. But if patients don't take the proper medication, the stent could get thrombosis or things like that. So those are the main things.
Thank you so much, Dr. Iseko. I think we've had a wonderful time this afternoon. Thank you, everybody, for joining us. We appreciate your time. We appreciate your patience. We appreciate your presence. Sorry we started a bit late today. Remember that tomorrow again at 4 p.m., we're going to be starting the symposium. But from 1, there will be the BLS session. We are going to have a few in-person people there physically, and we're going to try to stream that part live as well. So if you have a chance, from 1 p.m., you can log in to just see the practical part of the BLS session, but otherwise the symposium itself will start at 4, and we're going to be dealing with ECGs and the recognizing congenital heart diseases and the initial management for pediatrics. So thank you very much, everybody. It's been a pleasant day. Dr. Iseko, thank you so much for your time. It's been very nice.
All right, bye-bye. See you tomorrow, 1 o'clock or by 4 o'clock. But either way, make sure you are here. Please remember that you need to have the prerequisite amount of attendance to qualify for the CME. Thank you very much.